I think probably the number one driver of why EMS is not farther along in mobile integrated health and community paramedic programs is EMS.
We have to hear that sometimes we're our own worst enemy. We're the impediment. We can blame everyone else, but once we reflect to understand what that issue is sometimes it's us. Well, welcome to another episode of the Leadership Lab with Asbel, Montes, and today I'm just excited to have Dr. Charles Miramonti, and I'm going to call him Charlie, joining me here on the Leadership Lab. For many of you that have been watching and paying attention, we are talking a lot about healthcare. We've been talking a lot about leadership in general, but there's a lot, of course, happening in the world of healthcare. And I think the introduction of and the passage of the One Big Beautiful Bill Act has really accelerated some of these conversations. And the one thing that I'm really excited about, and I know there's a lot of information out there, people are still digesting the impacts. There's still a lot of data that we're looking at, but there's an opportunity within healthcare, specifically within the emergency medical space, related to some things that many have been working on for many, many years of the value that EMS can bring to the healthcare continuum. And so I'm excited to invite Dr. Miramonti to my podcast as we have a discussion here. And first, I have to give a shout out to Dr. Eric Beck for introducing us. He was probably my number one inaugural podcast was with Dr. Eric Beck, and really got some of the conversations moving around this unplanned, unscheduled care piece of it. So Dr. Miramonti, I'm going to stop talking here. I'm going to start calling you Charlie as well. Please. But I would like for you to kind of give us a little bit of your background for those that may not know who you are, but give us a little background in space and EMAs and then what you're currently doing right now. And then we're going to get into this conversation and really excited to pick your brain on a few things as we begin to develop out what we're doing here in healthcare.
Yeah, you bet. So I first got into EMS in college as a 18. I signed up as an EMT, did the ambulance through most of college as well, and then I used to go volunteer in the ER all the time as a med student whenever I could. Did emergency medicine as my residency. Graduated back in 2003. Did a fellowship in EMS medical direction, and got engaged with a bunch of the larger EMS services here in Indianapolis over the years. To make a very long story short, I was part of the group that led the initiative, I should say, to rebuild EMS here in Indianapolis, sort of merging a number of different fire and hospital systems into what is now Indianapolis EMS, where I served as chief for about 9 years. And then in that time, I also did a bunch of work in the hospital C-suite and med director for the emergency department and service line chief and all that business. And then one day I got really big into value-based care, and we were using some of our revenues on the EMS side to launch mobile integrated health platforms at the very beginning. This is like 2015, 2016. And community paramedic programs, social workers paired up with paramedics, MCAT teams back in the day. Like, we did a lot of that work, and I loved it. I got hooked on the value-based proposition back then, especially as it was relating to the pre-hospital world and primary care and emergency medicine. I just see all that as sort of a continuum. And woke up one morning and said I didn't want to do the hospital EMS thing anymore. And I moved over to a value-based care company called Oak Street Health, where we got some mobile integrated health platform off the ground here in Indiana, where it's very easy to do this kind of work. And after COVID, that turned into in-home primary care and running our in-home primary care division, and led that expansion and whatnot. And today I'm still doing that as we grow that arrangement with a number of our partners inside of CDS. But I'm leaving that arrangement and heading over to a company called Crosswalk Health, which is really now at the forefront of marrying up value-based and payer relationships with EMS and frontline providers. So right in the lane, which we're on topic today.
Well, I love that, Charlie. Well, that was a surprise to me. So everybody probably saw my eyes go, really? So okay, I didn't realize that you were going to Crosswalk. So, well, welcome to another. I'm sure that they're happy to have you on board as well. But let me kind of rewind, and I want to talk first about some of your EMS experience. And then I also know with your experience in Oak Street and more of a full risk model, really want to kind of talk about that piece as well. Because sometimes when people get into this full risk versus shared risk, there's this whole, when you jump, it's like jumping into the deep. in a full risk
It
model.
is.
Sometimes it's
Oh,
dipping
it
your
is.
toe for shared risk. But before you go there, let's talk about what you were doing at Indianapolis EMS. And you got into that value base back in 2015. And in the continuum, I'm very specifically interested into what, and I don't know if it was Dr. Beck that coined this, but the unplanned, unscheduled care part of the healthcare continuum. So I'm looking at this at the general healthcare continuum outside of just the EMS scope. I've been in EMS for 29 years, so sometimes that's all we look at it through the lens of EMS. We've got to
Mhm.
stop doing that. What part in the healthcare continuum do we have a portion of, and I really agree and believe it wholeheartedly, is in this unplanned, unscheduled. There's nobody like EMS that understands the logistics of it. We're
Mhm.
24/7, 365 providers. There's no other provider that really understands all of that piece that's coupled with the logistics of it for that unplanned, unscheduled care. So tell me about the involvement that you did at EMS. What were some of the models that you have? And I'm assuming some of them, you funded them originally, and usually most people say we started it, but the sustainability of the models, we had to wind them down. It was a very interesting stat that the mobile integrated healthcare individuals talk about, that I think it was like almost 2/3 of the programs actually terminate due to sustainability of funding. So can you talk a little bit about that? And then I want to kind of pivot to your full risk discussion.
So we first got involved in pursuing mobile integrated health and community paramedic platforms as another service line that which we could generate revenue on. You know, you're sitting here with an EMS system. You have millions in equipment and hundreds in labor force, education, warehousing, fleet, all of it. You've got it all sitting right there. And so, trying to figure out what can we do that's going to be different and new and really provide a value back to our hospital partners and such. We looked at non-emergent transport and all that stuff, and really for me and the leadership team at the time, getting into community paramedic work, looking at what had happened out in Wyoming and some of the early programs out there, just made a ton of sense because that would allow us to line up with hospitals and emergency departments across the county, which is 18, 19 different hospitals or emergency departments, I should say, and um, because of the way IEMS, which is still structured today, um, we were able to make quite a bit of a financial turnaround. Whereas, most large urban cities, you run at a deficit. You're on the city's taxes and the city's budget. IEMS came out from all of that and was its own self-sustaining model that we had built through a number of different efficiencies and restructuring and whatnot. And so we were sitting on some dollars where we could invest back in the communities differently, but it meant finding different provider types. And what we found was, and you've talked about this before, sort of the hero role that EMS and first response systems often only see themselves as. And so we really pushed on that ideology, pulled in older senior paramedics who had done the knife and gun club show for a long time. They were looking for something more meaningful, something that was more sustained. We built out, treat on scene protocols. We built out in between visits and ER follow up protocols. Built out, just the data, being like, who are our problem children within the community, and how do we engage them? And it was honestly, we pulled it was a 1984 paper that one of our ER social workers had written for her master's thesis. I mean, it was still sitting on like the dot matrix printer pages that she had held on to. And we took this sort of pre-hospital social work model that she had and then married it up with our infrastructure and then went forward. And we failed forward over and over and over again. One of my favorite failures, honestly, in that space is we were trying to figure out a business model was we paired up with a Medicaid managed care player and said, hey, we'll go in and we'll do all this X, Y, and Z work for your particular patient population. Here's your high risk or our high utilization patient population for our data. Um, let's do a pilot. And looking at total cost of care, which was probably a mistake back in the day, but we were able to easily demonstrate significant reductions in ED utilization, ambulance transport, and whatnot. But what had happened, and this is just how myopic the different industries can be relative to one another. What had happened was we were pushing people more into primary care and getting back in with their PCP appointments, medication costs, prescription costs went up significantly in that patient population because they were actually taking their medicines, but not going to the ER. And so, the insurance like, wow, yeah, we've increased our costs because of this program. I was, well, it's because people are getting health care, but what we signed up to do, we did. So,
That is a very interesting thing of what you just said, that getting the individuals to move more into preventative care. And this is,
mhm,
I am so going to pivot. And of course, folks, if you're listening, of course, we have an outline of discussion. I literally am going to pivot here. But the One Big Beautiful Bill Act really talks about, and this new initiative of Secretary Kennedy and Dr. Oz is really more about preventative medicine, trying to
mhm,
get people to be more healthy and to do things before they become a diabetic or whatever. But while you get them gradually there, that is a very interesting example that you just gave that could be part of an outcome that individuals that once they start taking their medications is going to prevent them from having to use the ED and other type of
mhm.
services, but there could be some type of impact or what have you. Tell me about what the managed care organization, you don't have to list it or name it or whatever that you can do or talk about, but can you talk about what their natural reaction was to look at the increase in pharmacy? Did they see
Right.
anything? Let's explore that.
Yeah, so we had done, I don't know, roughly 2 or 300 patients within the pilot trial. I think it ran for about I think it was about 6 to 9 months we ran the pilot. And, really this is a perfect example, and this happens with hospitals as well. This is a perfect example of not understanding the guy across the table and not being able to find that common ground. And two entirely different business lines, two entirely different incentive packages, if you will, on the kind of work we did. And so in those discussions where we're sitting down and just, we're beaming, walking in with this we've got significant data that says, hey, we're cutting ER visits and we're cutting transports and whatnot. And this was across all health systems because we were just doing this on a community level. And for them to come back and say, well, this is how we look at it, and this is, for us, everything is total cost of care. It's not just about what you do. This is the larger picture, blah blah blah. And I get it. It's very frustrating, but I get it. You run into this problem again inside of hospitals, and for those, there's a number of different stories in the primary care setting and in other settings, but those health systems that are strictly fee for service and are dependent upon those beds being filled, they shy away from these programs because these programs keep people out of the hospital. And so you have to find really like what's the common ground we're going to agree on. How do I, as an EMS agency, as a pre-hospital service, create a value for you as a hospital or as a payer or whatever? And those values are different based upon whichever market you're getting into. And that is a very, very different sort of math, if you will, from most EMS systems, not only in how we see ourselves as stepping outside of this hero role, but also in how we recognize value and prioritize services for our communities and our patient populations. I mean, it's been a painful lesson, but it's been fascinating over the years to watch this.
And Charlie, I think you hit in on something. That's why we keep reiterating it. And I know it resonated when we talked about the story brand concept of this hero guide, is we take ourselves out of the hero, we move ourselves into the guide, because you indicated about value. Value is in the eye of the beholder,
Hmm.
not you as the speaker. Not you
That's correct.
as a guide. I need to understand what the value is for the hero of their story. And it's going to
Hmm.
look different. So there's not a cookie cutter option. And generally, when we started to come into this, we thought it was going to be the same for everybody. And that is not what you saw here. Like, all of a sudden, it's like,
Right.
well, we cut the ED visits, but pharma started going through the roof and the pilot project ends. So I like how you talk about we failed forward many times as we worked through this. So I'm going to pivot to the next, what took you into that full risk side of things. Because when you start moving into a full risk side, it's like, okay, well, you're going to own the risk. Here's how we're going to pay. So let's talk through that because that's kind of it's not that it's a new concept to EMS providers, but it's a concept they really can't wrap their heads around.
Yeah.
What does that look like? So I'm really interested in your experience around that and what your perspective could be of how we could actually embrace maybe that there are some models that we need to be talking more about as full risk and how we could actually do that in EMS.
I guess to start it off, the whole thing around value-based care on the value equation is who's defining what the value is and what's actually valuable to that particular party. And that changes depending. From my perspective, and I think it was really in the emergency department that this started to grow in my noggin. But from my perspective in the ER, you see, especially in an underserved safety net emergency department, you see so much that is in the ER that day that never needed to be there, was easily preventable, that the ER was being used as a dumping ground and a low-cost solution for all sorts of failures within the larger health system, whether inside of a particular system or even across the county as a whole, or even on a national level. And so trying to figure out, because like in the ER, you see the pre-hospital side, you see the inpatient side, and you're also dealing heavily with the specialty and primary care side as well. So you're connecting lots and lots of dots and seeing where those connections fail and the outcomes of when those connections fail. So that got more thinking around, well, how do we make the ER a more efficient place, less of a disaster or, for lack of a better word, this sort of goat rodeo or shit show that it never needed to be, because there's so much volume in there that doesn't need to be there at that particular time. And so all these things around patient experience and provider experience and whatnot, it just made sense to start to dig into solutions that created value for the health system, for the patient, for the community at large. And I saw EMS again, because I'll say this over and over again, any EMS system is sitting on this giant logistics platform of resources that can be moved in any particular way. We've just only thought of it as unplanned care and emergency care. It doesn't need to be. There's no reason it can't sort of step outside that space. And so as we got into more pilots, we focused on diagnosis. We'll go after COPD and CHF, or we'll pediatric asthma pilots. All of those successful, but never at a large enough scale where you could convince the right person at the right time that it was of value. Because, if you're coming back to the hospitals and say, hey, look at this great thing we're doing for your emergency department, it's like, well, you're cutting our admissions. You're cutting our readmission. We make money when folks readmit. And I get that. Everybody's got to eat. You got to keep the lights on. And then from the payer side, as I said earlier, with the their perspective on total cost of care and whatnot. So I think there's clearly a need. It's trying to figure out how to match the need with the payment and incentive models depending upon who you're talking to at the time or where you're trying to generate some sort of risk arrangement. And that risk arrangement is predicated upon what's valuable to the guy across the table from you or to the other party across the table from you, if you will.
Let's kind of expand on that just a little bit, because this is what we hear all the time, that there's all these moving parts. The hospitals are saying, well, wait a minute, we need the readmissions because that's what keeps the lights on, to use your words. And what we do know that is undisputable is the rising cost of healthcare.
Mm-hmm.
Okay, that's kind of whether we like it or not, it's uncomfortable as a healthcare industry in general. I'm not just talking about EMS, but the healthcare industry is having a very uncomfortable conversation right now. And instead of reflecting, it's almost like we're deflecting and saying, well, if the payers would pay us more, or if somebody else would do more. And I was having this conversation earlier with a group about, we have got to be honest with ourselves. And we have to be honest and say, and this is the analogy that I gave, was around, we are saying there's no waste and abuse in our system, but yet we're pushing back about transparency in our system.
Yeah.
And if you are an outsider looking in and someone that does not want to be transparent or open up something, it makes this think, well, then what are you hiding? And maybe you're not hiding anything, but just the illusion of pushing back on it gives us that. And this is an uncomfortable conversation that we need to have. So I want to unpack something that you said. And I want to unpack that, being an ER physician, how you talked about there are people coming into the ED, it's kind of a dumping ground for them. They don't really need to be here. But also, if we try to divert them away, then we were feeling the pressures of another system saying this. And I will tell you from my experience, and I deal a lot on the policy side. I've got a lot of friends. I understand how the thing works. They know this is going on. And I remember a conversation that happened with a former undersecretary or deputy secretary for an administration that basically said to us a few years ago, is the only way that sometimes you can get behaviors to change is to put downward pressure on rates and to make it about finances until it gets
Mhm.
to a point to where the outcomes begin to show, okay, maybe we've pushed about as hard as we need to push. It's kind of like the stress test.
Yep.
And I believe we're under a stress test right now as a healthcare industry. And if we do not begin to think outside of the box of things that you're talking about with EMS, I cannot control what others in the healthcare continuum do, but I can control and understand the value that we do bring. So can I
Mhm.
guide that value to the appropriate individuals? And maybe we've identified the wrong heroes in the story. Maybe it
Mhm.
isn't the hospital CEOs. Maybe it is a regulator. Maybe it is a mayor. Maybe it is something else in the community. And so, in your work and in your line, as you continue to move this out, and you've had some successes as you've dealt with Oak Street with Stevie, and now you're moving to Crosswalk because there's a lot of movement here. There's a narrow window of opportunity that we have. Tell me where your thought process, where should we go? What should we do? You're obviously making some changes as an ER physician. You
Mhm.
see something happening. And so if you're either protecting or preserving or adapting and innovating, and you're adapting and innovating right now. So can you take us through what you're seeing? And of course, you're just reading the tea leaves right now. Here's what I see happening. We've got it is pivotal. And I know my conversations that I've had with others in the industry speak very highly of what you do. It's why I wanted to have a conversation with you, and I'm glad we're having this dialogue. But not to put you on the spot because I am going a little bit off script, but you're bringing stuff, and this is kind of the conversations that we will have, and I am happy having uncomfortable conversations, but we've got to have them as a healthcare industry to make that
I
happen.
agree. I
So
agree.
so talk to me a little bit about this. I've heard what you've said. It sounds good. I get it. We're maybe dancing a little bit politically right now. I don't want to dance politically. I mean, we have to have these hard conversations. We have to do something different in healthcare. We cannot keep doing what we've done. And so, talk to me about what you've done at Oak Street. I'm intrigued by that. These full risk models, I think we're onto something there. I think the government wants you to do something as well around that. They want us, the healthcare providers, to take a bit more risk, have a little more skin in the game. So, talk to me a little bit about that.
Just starting on the Oak Street side, probably one of the more important advances we put forward in our in-home primary care model was marrying up a variety of EMS-based principles with in-home primary care. And primary care, especially on the in-home front, is moving more and more towards advanced practice providers. So there's tremendous variance in experience, there's tremendous variance in training, and there is tremendous variance in practice as a result. I think you get that in any primary care, even physician-based group, but I think within the APP world, because of all those different variables, there is tremendous variance. And variance, in my opinion, is a killer in the value-based arrangement. Because I think what is so important, and that I learned from the Oak Street brick and mortar model, was that being able to create the same experience for any given patient across a number of different geographies and social dynamics and resources and whatnot, but creating the same approach, using the same well vetted, evidence based guidelines across chronic condition management, hospitalization prevention, all those things. Marry that up with a little bit of hustle. And I think that's sort of the winning equation in terms of reducing or variance in the value based space. And so what we did was we took a protocolized based approach, taking national guidelines on COPD and CHF management and all the number of chronic conditions that were really driving hospitalizations, driving costs for a variety of folks, in addition to all the other barriers. Taking that protocolized approach across chronic condition management and then driving that with lots of education, lots of hands on with medical direction, lots of times teaching and shadowing, all that sort of things to develop your providers, not to do checkbox medicine but to really be able to use the algorithms out there effectively, save your brain for the hard stuff, and go forth and create and driving that consistency across every market we were in, across every team that we were working with. I think translated very well into hospitalization reductions and decreasing costs of care. To do that at scale is very, very difficult. It's hard to do that without diluting the model as the number of providers goes up and all the places you have to be at one time, your onboarding and your training, all this stuff really kind of comes into it. And then that doesn't even begin to touch on how important the data is into doing population health management and value-based arrangement. One of the hardest thing I think is for many providers to transition into value-based care is there's a ton of feedback. You get a ton of feedback on your practice. And a lot of folks don't like that. But you're going to get, here's how all your CHF patients are doing. Here's how all your hypertensive patients are doing. Why aren't they doing better? Here's where your gaps are in your prescribing. Here's where your gaps are in screening and prevention, blah, 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 blah. There is no excuse. You have all the data in front of you, and you have to be able to incorporate that every day relatively quickly and be very good and nimble with that. So I think all those things become important in the value-based space. But a lot of those same principles also apply to the pre-hospital environment. And being able to take some of those principles back to the pre-hospital environment and say, let's look at this a little bit differently. Let's look at how you create value, not just by going lights and sirens to everything, but let's look at how you create value in connecting payers with very hard to find people, connecting payers with networks of other providers that they otherwise would never have access to, health systems that they would never otherwise have access to. And I think what is such a, this is all comers, fee for service, value, everywhere. I think access to care is just so difficult today. It is such a problem is to get access to care. And 911 is just this automatic default. Oh, I can get access to care if I just call 911. And for a lot of folks that don't have other resources or they don't have trust in the health system, that's their default. So why can't we put solutions in at that point in time? Why can't we put solutions in that change the game a little bit for EMS to be a better partner with health systems, to be a better partner with payers, and to be a much better partner for our communities by putting folks into the resources that they're actually after, rather than just dump back in the ER and let the ER doc solve for it.
Have we done, and I want to unpack one other thing. I could talk to you for a while here. So I'm going to try to stay on script as much as possible, Charlie. But you made a statement here that you guys gave data. Lots of data was going back to them. And you made a statement where you said they would get the data, and for obvious reasons, there's just obvious that some of them didn't like it. And can you unpack it? To me, it seems obvious, but I don't like to assume why they may not like it, usually when it's transparent. But tell me what they didn't like. Is there something about the data that you guys were providing back to them that they did not like? What did they not like?
I think it can be overwhelming to have that amount of data at your fingertips and not be able to act on it. You know, in most, I shouldn't say all, but in most value-based arrangements, typically the panels are smaller. You typically have more time with your patient, but you still have a very busy day. So you've got a small amount of time to plan ahead. And you have a whole care team. In most value-based arrangements in primary care, you've got a whole care team to coordinate. So I need to listen to my behavioral health specialist. I have to listen to my social worker. I have to listen to my MA and my nursing teams and whatnot. And I have to coordinate them. I have to get everybody on the same sheet of music, and this is the playbook for the day or whatever. And to do that over and over again, I think is very, very difficult. And then, here's your 9 million spreadsheet on your coding and documentation performance, and here's here's the diagnoses that you missed on your particular visit today. Look, they're back in the record from 3 years ago, so on and so forth. And that can be really, really, really overwhelming and challenging for folks who just want to come in and came up in a different world, if you will, of a different identity of what it is to be a doctor or be a provider. And I think that's very challenging. And so I have always found that the folks that are best at that are the ones that can manage the information quickly, efficiently. They put lots of processes in place that they just repeat over and over and over again, saving their brain for the hard stuff later in the day. And they're just efficient because they rely on process so much rather than just all the one-off stuff, and I'll just wing it as I go into every patient case, which is, I think, so very challenging for folks to do in the value-based arrangement. Does that make sense? Am I answering your question?
Yeah, makes total sense. And because it allows me to pivot to what I really want to talk about here, because you kind of we talked about the data, and data is going to be key for individuals within EMS. Okay. There's a lot in the hospital. They have a ton of data. Now, how they measure it and sometimes the metrics and the outcomes of things, they're looking at multiple. I know one time somebody was telling me about a value-based model that had 23 different metrics. I'm like, are you kidding me?
Yeah.
Like that's way too many metrics right now. Like, I mean, how are we like moving slowly through the process? I mean, it should be crawl, walk, run. I mean, if you come right out of the gate with 23 metrics, there's no wonder why people feel overwhelmed or they don't like that I'm trying to take care of patients. And that's kind of what I'm hearing from you. That's why I wanted to unpack that a little bit. Because
Yeah.
that takes us to where we are with EMS. As we move into the healthcare continuum and we really begin to understand the outcome side of it. So this is the reason why I'm engaged a lot with Dr. Beck when it just had aha moments when I found out that, 40% they have 40% of the data that has a longitudinal record side of it with the EMS side. They actually have a really comprehensive data set. That doesn't mean that there's not other vendors out there doing it. It's
Sure.
just we got a vendor here that can actually prove a point. And are there 2 or 3 metrics that we should be looking at from an outcome perspective? Then we have clinicians such as yourself that are coming on board that are astute in the art of understanding emergency medicine. No disrespect to all my other specialty counterparts, but I really want to understand and talk to those physicians and clinicians that can understand it. Because there's always been this thing, and it may have been it's been to ourselves. I've only just been in the EMS industry for 29 years, and as I've explored through the process, understanding I'm not a clinician. I just look at it from the financial side of things. But things that don't make sense to me, because to understand is people will treat you the way that you act. And so somebody told me a long time ago, Asbel, before I ever hear you, I see you. And so if you look like you aren't confident in your ability or whatever, if you looked like you're not suited up, if you look like you just rolled out of bed and you're coming to take care of them, that's the first impression that I have of you before I even understand what you say and what you do. So I apply that with anything that I do. Before you
Sure.
hear me, you see me. That's what I see about EMS is before the regulator hears what you have to say, they see you, they watch you. Can you do it? And so part of me believes we've got to begin to understand who we are as an EMS industry, believe where we are and placed in that. And then the outcome data will start to show. And then the clinicians, people that you talk, there is a continuum for this. Here's the one thing that I want to pat because you started talking about we had to do a lot of education. I'm on a flight about 4 months ago, flying, and somebody sits next to me, and I could tell she was a nurse. She sat beside me, and we started asking. I started saying, "Talk to me about what do you do?" And so she started talking to me about.
Are you that guy on the plane? Are you the guy that's like,
Sometimes,
I want to talk to you?
sometimes I'm the one that puts the earphones in, but when I
Yeah,
saw
that's
her in
me.
her scrubs, I'm like, "You're healthcare. Let me ask you what you do."
Yeah,
And it
yeah.
was the most interesting conversation that we had. And we started talking about home health, and I'm like, "Well, I'm in EMS," and we started talking about the EMS. She said, "You know what? EMS. I'm an old nurse." She said, "I've been doing this for 40 years." She said, "The nurses of my year, we could do everything."
Mhm.
She said, "The new nurses coming in now," and this is nothing against my nurse counterparts. I love them to death. I've got lots of friends. I have my business partner's wife is a nurse.
Mhm.
They're like, if it's not within their scope, they're like, "Oh, they have to do that, not me." And she said, "I used to be able to do everything." She says, but with EMS, they will do literally, they can do more than they will do everything. And she says they're vital to fixing the EMS. Well, I got her, and of course, when she said that, I'm like, "Oh boy, we've got to have a conversation." I have her. I want to have a conversation because I think that's where it gets down to. It's the mindset of what could happen, and EMS can fill a gap because they're protocol driven.
Yeah.
There is this training that we can do. Some people talk about maybe they need to be a mid-level practitioner. I don't even think we need to get into those conversations right now because then you introduce politics into it and territorialism. But if we can understand this piece. So generally from your perspective, I'm just sharing that's with me. That's just the conversation that we were having. And I'm thinking there is something here that if we'll begin to own who we are. Stop trying to be something that we aren't. And this is going to be a controversial statement, but people know I'm known for that. This whole advocacy work that sometimes we use about we need to be credentialed providers. We need to be kind of like they have as a RN, then you move to a physician as a nurse practitioner, then a physician assistant, and it just kind of moves you through the process. Not that I'm against it. I'm just thinking, can we own what we do right now? Can we show the value of that before we move to the next step? Or do we think a credential brings the value? And listening to the conversation with that nurse, I'm not quite sure she even thought the credential was of the same value, because she said the nurses, when I went around, could do all of this, and now it's a whole different story. So I'm not
Yeah.
really sure that the value proposition was still there.
I think for a number of reasons, and I'm biased for sure, but I think the way Indiana and many states like Indiana are set up, where the medical director is sort of the sponsor and overseer of the paramedic and EMT provider, is really, really wonderful. It allows so much flexibility in what that paramedic can do, which is what's going to be required, as I've mentioned earlier, as EMS systems have to figure out how to be flexible and nimble and adapt to different value equations for different partners. You're going to have a provider that can be very, very flexible in that space as well. And so I think, the way paramedics are trained today is incredible. I think it's evolved to something that is just outstanding. You see a lot of push on the education market in the pre-hospital space to go from, these quote unquote zero to hero programs, where you've got no prior EMS experience or training or healthcare, and we pay you to go to EMT school, get your experience on the street, pay you to go to paramedic school, and we're grooming folks much faster than we ever were, and I think more effectively than we ever were, because of the marriage of the street experience with the intense classroom training and not having to work 9,000 hours in order to make it all work for the employee. I think we should absolutely be leveraging all of that as we get into different niche work with these pre-hospital programs, and being able to do more treat on scene, being able to do non-transport work, being able to reroute folks differently, put more resources and more clinical decision support tools in the hands of the on-scene providers. I don't see a value at this point, where it's just so early into creating more credentialing and complexity to it. I think a perfect example is, many services provide, ground ICU transport or whatever, and they have to have a critical care training to go along with it. Well, that's great in a highly urban, high volume environment. But what about environments which is 90% of the rest of the country, where you have to be incredibly flexible, and that paramedic has to be able to go get the cat out of the tree, and also work a motor vehicle crash, all the resuscitation skills, and still go, later to do CHF exacerbation management and whatnot. So I think trying to box the provider in is a mistake at this point. We're just not far enough along, I should say, to go down that road. And I think it would be hamstringing any evolution, especially any rapid evolution of the program. Having provider oversight, having appropriate training programs in place, should be part of the requirement. That should be baked into the evolution of these provider capacity or capabilities, but not having to credential everything along the way. I think it's just such a number of barriers, and we need to go much faster than we're going today to get out of our own way. I think probably the number one driver of why EMS is not farther along in mobile integrated health and community paramedic programs is EMS. I mean, we are so rooted in our own regulatory environments and our fiefdoms, the way so many states are structured. It is just a disaster to try to go and do something new or implement new protocols. I will tell you, when we try to expand mobile integrated health platforms outside of Indiana into other states, Oak Street, incredibly difficult, because you had to every 5 zip codes had a new medical director board and had different regulatory requirements, or they were owned by this hospital and you had to go to that hospital, and it was very, very different. East Coast EMS is incredibly different from Midwest, is different from West Coast and Southern EMS systems in the way that they're designed. And I think all that has to be taken into account for. So I would say, back to your original point, the more we're getting out of our way with all of this paperwork and credentialing for the sake of credentialing just doesn't make any sense to me.
So I hope our viewers have heard what you just said. And to be honest with you, I'm going to bring this out into a 90-second short, what you just said right there, because I think that's what our industry has got to hear. We have to hear that sometimes we're our own worst enemy. We're the impediment. We can blame everyone else, but once we reflect to understand what that issue is sometimes it's us because of all of these boards. I'll tell you, I am excited because I think we have a window of opportunity here. And there are a lot of us that are doing things not behind the scenes, but we're just doers. We're done talking about it. Let's just do.
Yeah,
And I believe you have actually said exactly the way this needs to happen. And I think when we were doing some things, we kind of got the cart before the horse. And really, these models should have been really developed at the state level first, then adopted
I
at
agree.
the federal level. And there is a propensity in this administration to make that happen. And there's a lot of dialogue beginning to happen around that. So here's what I want to ask you as we start winding down, because I've got two questions for you. And one is, did not realize earlier that you have moved through transitionary from EMS. You've went to Oak Street that's done some stuff in the primary care models, and now you're moving into crosswalk. I'm sure some people are trying to figure out, what is crosswalk? Can you tell us a little bit about what that is, where this transitionary that you're moving into it, and how does that intersect with EMS? I know how that intersects with EMS because I know the company you're talking about, but I just want to
Hmm.
make sure that I understand, and I'm going to have a follow-up question for you, and then we're going to end the pod. But you've given some great nuggets that I hope the industry hears as we work. But tell us a little bit about this next transitionary phase of what you're going into.
Yeah, so crosswalk at its core is sort of nurse navigation inserted into the 911, into the PSAP, if you will, at the 911 when you call in. And what it allows for at its most base form is rerouting essentially of one is rerouting of folks away from the emergency department into what is really the appropriate venue of care for them and helping them to get there at the same time, creating additional resources and additional options for folks so that they just don't have to go sit in the ER for 4 hours and hope somebody can route them to the next thing. And then also, I think the real value with Crosswalk is creating networks of additional providers in the EMS space, connecting them with health systems, connecting them with payers, and creating that access for payers into the pre-hospital space for patients that they can never otherwise find or manage or route, if you will. And why can't we provide those services at the time of their need when they're calling in? And take a breath and let's walk through this and figure out what you really need, and then let's get you to where you really need to be. And it's just, right now it is at its earliest phase, but the ability to connect into so many different parts of the health system, the ability to drive performance metrics for payer programs and managed arrangements, the ability to create tremendous amount of community resources for uh, uh, the municipal administrations to reduce the burden for EMS systems on urgent and emergent transport. Same thing with fire systems as well, and really just it's like EMS 2.0, right? It's like it's taking what was born out of the early trauma papers in the 60s and now redesigning everything and creating the connectivity, and then hopefully the policy, and then hopefully the reimbursements in some way, shape, or form that are going to drive EMS to be such a much better partner than just simple emergent response, and really be that access point for folks down the road.
And what I'm excited about is we have data now. We have
Yeah,
a lot of
yeah,
we have outcome data that really shows what they call these low acuity calls coming in that are high utilization. And so they're coming through the system and they could actually be navigated out of the system. There's models that have anecdotally done it in their own communities. I know there's others that are doing something similar through the process, but it provides this window in education that if we can get it down to the state levels, understanding this piece of it, it
right,
models up to, I know the ET3 model actually had put out a thing to kind of do a quasi nurse triage thing, and they were going to
right,
actually, but
right.
they never went through with it. And there was just a lot of things happening at the time, but that has actually centered again. There's a lot of discussion happening around this. There's outcome data. I'm always highlighting ESO right now. People are probably like, does he have somebody asked me the other day, is he Do you have some vested interest in it? No, I don't. What I have a vested interest with is I don't care who it was. If Epic had the information, for God's sake, we do it. But they
Yeah.
have the EMS integration of the longitudinal data that can prove some of the stuff that we're doing. So if you could look in your crystal ball, so you're going to Crosswalk, you're looking at this. They're obviously in this market where they can move out some of the individuals out of the EMS system, calls that they don't need to go on, calls that ER visits that don't need to happen because of this, because they just need something around SDOH or what have you.
Hmm.
If you could look at the next 6 to 12 months, your background as an ER physician, being in EMS, to primary care, and now to this piece, what would you say in your mind's eye that 2 or 3 things that the industry, that EMS really needs to focus on to take advantage of the environment that we're in to do something different?
Two things. One would be on the regulatory front, as I had mentioned earlier, is to follow the lead of Indiana and many other similar states that have created pathways to mobile integrated health platforms, created I think the educational and the requisite regulatory reforms needed to allow these programs to evolve across large geographies. I think that's really, really important. And then secondly is I think EMS systems have to stop looking to uh, Medicaid, Medicare, and government funding, and really start to figure out. Let me rephrase it this way: they need to stop looking at government funding, tax subsidies, city budgets, municipal budgets, and whatnot, and figure out that their new best friend is going to be the payers in their market. And that's where I think the relationship is really going to have to happen. Because of the way the money flows, it has incentivized and driven how we see ourselves in EMS today. And I think being able to pull the payer partners into these conversations and innovate with those relationships is just going to be so important moving forward.
So I'm going to leave it right there with our listeners or whatever. But if you don't mind, if the listeners want to do something, I'm going to provide some information if they want to contact you, reach out to you to get more perspective. You really bring a unique perspective, but we need to have more of these conversations. And the one large takeaway, I know reimbursement's always something. I'm going to hear people giving feedback. Well, I get what he's saying, but Medicare, Medicaid are a lot. Like there's a lot of things that to unpack in your last statement, but I actually just want to leave it there because it needs to sit and permeate with the industry and to also understand, get out of the hero mentality. That means EMS is our problem. Begin to start guiding who's the
Exactly.
person that's going to get the value. So, Charlie, thanks for joining me today on the Leadership Lab. And hey, welcome to your new
Oh, thank you so
gig at
much.
Crosswalk as well. So,
Yeah, I am super excited. Very, very excited to get down the road. So, yeah, thank you so much for this opportunity, and I hope we keep these conversations going.
and we will as well. But so thank you for joining the Leadership Lab.
Take care.